Hi everyone, my name is Rich Brock. I'm a fourth year medical student. I put this presentation together titled Personal Growth and Feedback because I feel like feedback is, oftentimes lacking in medical education. It's underappreciated, but I think it's an important thing when done correctly. So the objectives of this are to guide students in navigating feedback conversations, preparing students to generate SMART goals, recognizing the presence of bias in feedback in clinical training, and having some techniques to minimize bias in the learning environment, and preparing students to deliver effective feedback with the ART framework. So just some quick context and disclosure. I personally haven't received a ton of modifying feedback. I've kind of primarily improved myself, I think, by kind of observing people doing things that I wanted to learn how to do, and having that as kind of a driving force. And I feel like feedback is tough. It's tough for a number of reasons. Like it's hard to do without a longitudinal relationship. I think trusting relationships are helpful in delivering and receiving feedback. And there's not a ton of training about delivering effective feedback and receiving effective feedback, and so that's kind of why I kind of wanted to put this presentation together. And so just kind of setting the stage, I think it helps to think about how do we get the most out of our training. We start in medical school, and the first year or two are pretty classroom-like, school-like. But once we get into the clinical training environment, it's a lot less school-like. There's less of a focus on assignments and classroom work. It's more kind of learning on the job and kind of that clinical experience. And so I feel like feedback is important in medical school residency and beyond, in terms of kind of getting the most out of our training and becoming the best and most competent physicians that we can be. And feedback and evaluations are a large part of our growth. And you see yourself, you're a fourth year right now, and pretty soon you'll be in residency, and every single residency program has some form of teaching expectations. And so you're going to be mentoring medical students. You'll be giving feedback, and they're going to be watching what you do, seeing how you interact with patients, other learners, and you're going to be role modeling, I think, how you expect them to perform as well. And so you'll have a tremendous impact on medical students. And ultimately, I think this journey is about us and the people that we train, and helping them become competent, trustworthy physicians. And I like to frame feedback and education and where we're going based on this thing called competency-based medical education. And it's kind of grounded in milestones and competencies that you achieve, that you're expected to achieve before you graduate or move on to the next stage of responsibilities. Right now we have something called time-based training, where medical school is 4 years, residency is 3+ years, and as long as you pass your boards, you're certified, right? But who, it's kind of arbitrary. Who determines that medical school should be 4 years, that residency should be 3+ years? At the start of the pandemic, we were seeing plenty of cases where medical schools were actually graduating fourth year students early. And so if medical schools graduate students early, if they think that, halfway through your fourth year, you're already ready to practice and have a job as a doctor, and with some supervision, of course, then why is medical school still 4 years, or what makes you qualified enough to graduate earlier than 4 years, right? And on the flip side of things, there was a study of anesthesiology program directors that actually said that they did not feel like some of their residents were ready to graduate from residency, even though they finished their program and the number of years they required, they were boarded. And there was a survey, and they said that they did not trust some of their graduating trainees to care for some of their family. And so I think it's really important that we think about this competency-based education style of hitting those milestones. And it's interesting, there's actually an internal medicine program in Cincinnati that's testing a competency-based time variable curriculum, meaning that once you hit your expected competencies in early and intern year, then you move up. You're no longer an intern and you're a second year. You're doing second year responsibilities. And I think that could be a really innovative and cool way of approaching this. And just kind of getting at examples of what some of these competencies look like. These are the competencies for some of the competencies for internal medicine. And so some examples of things that are, needing improvement in a trainee are if, someone's unable to acquire an accurate history in an organized fashion, if they're missing physical exam findings that are important, if they are only able to develop a limited differential diagnosis and they're missing important diagnoses that could be contributing to the patients in front of them. And then some qualities or competencies that mean that this trainee is ready for unsupervised practice. These are the goals of what trainees should be achieving. And that's, acquiring accurate histories in a hypothesis-driven fashion, and that's efficient. Performing accurate physical exams that are targeted to the patient's complaints. And then, the aspirational qualities or competencies being, obtaining historical subtleties or sensitive information that are important for the differential diagnosis, getting subtle or unusual physical exam findings, and moving from that learner to teacher role, role modeling and teaching while doing your history, physical, or other kind of patient encounters. And so, these competencies, I think, are kind of what we should be striving for. And I think feedback is an important part of getting towards those competencies, of having someone tell you, okay, this is what you need to improve to reach this competency, right? And so feedback is specific, non-judgmental information given in relationship to a standard with the intent to improve performance. And so while people traditionally understand feedback to be one way, teacher to learner, I'm going to give you feedback, I'm delivering you feedback, it should actually be thought of as a two-way conversation, because teachers or attendings are not they're not perfect, and they could use some feedback to improve in how they teach and work as well. And so this idea of feedback conversations, it's relatively new, and you can be better prepared for feedback conversations and your rotations by thinking of goals you want to get out of each rotation. And a good framework for this is developing SMART goals. SMART goals are specific, measurable, attainable, relevant, and time-based or timely. And a tip for determining or making your own SMART goals is to look at the course objectives. And the course objectives can help you find kind of specific things that could be goals. Examples of things that are not SMART goals are, be a better student, be helpful, learn how to diagnose and treat patients. These are goals, but they're very non-specific, and you want something more specific so that you can see whether or not you're meeting or reaching that goal. So some SMART goal examples for the internal medicine rotation: deliver a well-organized oral presentation, formulate an effective and accurate assessment and plan, efficiently and comprehensively interview a patient, organizing patient information effectively, things like that.